not with us today. He's, I was going to say, sunning himself in Ireland. I'm not sure that's quite the right term, but he's currently in Ireland. I suspect, knowing Jeff, that he might be looking in. So we're all behaving ourselves. But nice to see everybody. Apologies, Richard.
We have apologies from Councillors Butland, Henry, Hoy, Robinson and Brown.
Okay, any substitutes? Okay. Swiftly moving on with the previous meeting. Are everybody happy that I sign those as a record?
Yes, agreed. Yeah.
Can I just make the points that were made in the pre-meeting on chasing up the information that's outstanding?
Yep. Okay. Duly noted.
Thank you.
Okay. Questions from the public?
No questions.
One day it's going to frighten us.
Yeah.
Okay. Item 4, we move swiftly on. East Suffolk and North Essex NHS Foundation Trust. With regards to the league tables, we have Nick Hume with us this morning. So I'll hand over to Nick.
Thank you, Chairman, and good morning, everybody. I'm delighted to be here this morning. So just very quickly, just to share a bit of background here, the NHS has now moved to a national oversight framework, which is helpful in some ways. I think in terms of really understanding when we compare our delivery around quality, money, access, compares ours with other organisations. Now, the difficulty is if you look at the league tables, not surprisingly, specialist trusts like Moorfields and Royal Marsden and what have you always come up right at the top because they don't have some of the challenges that we face in terms of open access for A&E and outpatients and everything else. But I think it's start off by saying I am, as Chief Executive, disappointed in terms of where we sit in the league table. Some of you who have been around the county for many, many years will know that Colchester always had a really tricky time until we merged in terms of really giving confidence to residents and to citizens that they could be assured of the quality and the timeliness of the care. We have improved that significantly over the last 8 years and have always enjoyed a position both regionally and nationally of performing above average. At the moment, we're slightly below average, and that's not where I want to be, and it's not where the organisation wants to be. So my aim this morning, briefly, and I'm sorry I can't stay for your whole meeting, is to talk about where we stand around our access around community, our community responses, our cancer responses, our elective responses, and indeed our emergency care responses. But perhaps more importantly today, to give you assurance that we are aware of the issues, that we are addressing the issues, and we have just gone through the biggest transformation that any organisation can go through in terms of our implementation of an electronic patient record, which is so much more than just removing paper from our organisations. And I'll talk briefly about the benefits that we think will come out of that. First slide, please. Thank you. So just to show where we are in terms of the challenges. So in our 18-week referral, now we have to remember, of course, 18 weeks has not been delivered in this country for 10 years, if not more. I know there's currently conversations with the national team and the DH, Department of Health and Social Care, which I'm involved in terms of understanding whether or not that is still an appropriate target, given that we haven't actually delivered that for over a decade. But we are doing, we're not doing brilliantly, but 56% of our patients, and the aim is to get that to 100% by the end of this current administration. Very clearly from the Prime Minister, he has set that ambition and set that challenge to DHSC. For our cancer waiting times, again, you can see that we're not quite hitting that target. Again, there's nobody except in specialist hospitals achieving that target, but that just shows where we are at the moment. We are doing better significantly better in terms of our community urgent response time. And that's really, really important. On the Colchester site, we see nearly 600, between 600 and 700 patients a day at A&E and our urgent treatment centre. So anything that we can do to reduce the pressure on A&E, particularly in terms of then avoiding corridor care, which is the scourge of the NHS at the moment. So that really quick community urgent response time. And basically what that means is it's another alternative that the ambulance service have in terms of avoiding a conveyance and therefore a possible admission to hospital. So really pleased that we are addressing that community response, and indeed sits very well with the government's 10-year plan in terms of shifting care from hospital to community. And finally, as you can see for North East Essex, for our 4-hour standard on the Colchester site, we are exceeding the national standard. Now, overall, as an organisation, we're not quite where we need to be at 78%. That's because we're having more challenges at Ipswich site. But again, because of the very high numbers that come through Colchester, and a lot of those are urgent treatment centre, about half of those, in some ways it's easier to achieve that 4-hour standard. So some challenges in there, not out with any other challenges that people are facing nationally, but that gives you some idea about where we are. The next slide, please. So I alluded to my introduction there. So EPIC is the most extraordinary transformation that I've seen. So basically at 5:30 in the morning on the 2nd of October, we went live and replaced 52 IT systems with one IT system. Paper disappeared from the organisation, just to give you some idea. So since we went live, we've saved over 2 million sheets of paper being printed, and just some really good impacts on the environment there that you've seen. But much more important, what this has done is free up time for our clinicians. Just to give you an example, yesterday I was on the ward talking to a physio. She said it used to take 20 minutes to refer a patient to a rehab bed. It now takes one click of a mouse. So giving that clinician 19 minutes back. And immediately in my head, I'm thinking, what are you doing with the other 19 minutes? But yeah, that's for another conversation. But they're really transforming everything that we do in the organisation. It will take a while to see those benefits. It will take a while to see how we can really improve on our excess targets, whether it's emergency, elective, or indeed our cancer targets. But EPIC is the best opportunity we've had. The success of ESNEFT over the past 7 or 8 years means that we have been able to afford EPIC. It is the most expensive in the world. It is also the best in the world by any measure. Touching as much wood as I can possibly get out to, it is being described as the best go live, certainly by EPIC, the best they've seen in Europe. So you often see major problems after go live, not being able to report, challenges for patients. There have been some. But for me, in terms of really giving patients control of their own health, which is our first and most important strategic aim as an organisation, is the introduction of MyChart. So MyChart gives patients and their families the ability to have all their information, all their results, all their appointments on their app on their phone. Now, it's not for everybody, because not everybody has an app on their phone, but we know that over 86% of people do regularly use their smartphones. And even if somebody doesn't, my mother, who's 92, is not great with her smartphone, but she can, to live locally, she doesn't, but she could allow me or give me the opportunity as a proxy to manage through MyChart. Just a couple of examples of that, personal examples actually. I had an outpatient appointment on the Monday after we went live. By the time I'd left the outpatient clinic and got back to my office, the GP letter was on my phone. I then had a blood test a few hours later. Within 45 minutes, the blood results were on my phone. Transforms healthcare, really gives patients and their families control of healthcare, real access to information about what's happening to them, and crucially allows them to have direct contact with their clinical teams. So all of this is about efficiency, productivity, but also around quality and safety. The very clever algorithms that I simply don't understand for example, will pick up as you automatically, or as you put in information around blood pressure and temperature and everything else into Epic, it will automatically trigger if, for example, there's a risk of sepsis. So not only around saving and improving lives, but also about saving and it's really improving the opportunities that patients have to have control of their own health. We've also, actually on the same day as we went live, which was an interesting risk that we took, opened our brand new endoscopy unit on the Colchester site to really work alongside Europe's largest elective orthopaedic centre, which the people of Essex can enjoy on the Colchester site. So SEOC, as we call it, the Dame Clay Marks building, gives local people the opportunity to have state-of-the-art treatment for orthopaedic elective care. And we're really starting to see some of the benefits of that now in terms of efficiency, productivity, and of course, because it sits outside the main hospital, will never be impacted by the traditional winter pressures where people often have to have their elective operation cancelled because of the pressure through our front doors. Next slide, please. Financially, we are a large organisation. Our turnover now is 1.3 billion pounds. I was talking to the first finance director that I worked with when I came to the East of England at Ipswich Hospital yesterday, and he was reminding me that the turnover at Ipswich Hospital when I became chief executive was £250,000. I thought that was a lot of money then, but of course we are a very large organisation. I say 1.3 billion turnovers, 12,000 staff, affecting 10,000 lives every day. We have achieved break even for the last 7 years. It is difficult this year. I think it's the most difficult financial environment that I've faced in my time as a chief executive. But we are, and this is one of the factors we are measured against, we are maintaining our plans to break even at year end, and that will take us to 8 years, which is pretty much unprecedented across the region. And why is that important? It's important not just so I can have a warm feeling on the 31st of March because it's green at the bottom right-hand corner of the spreadsheet. It's important because this generates cash, and even more so going forward, that if we do continue to break even, we'll be given more flexibilities around investment. And as an organisation across Suffolk and North East Essex, we've invested over £400 million in the last 5 years in terms of infrastructure. So really making a difference, as I say, with 2 new departments at Colchester, SEOC, which I talked about, a new interventional radiology department, and a new endoscopy suite. So really investing back into the community. So final slide, if I may. Thank you. So we recognise that we have these challenges, and so there are a couple of things that we've done. First of all, we've appointed 2 new directors, one to work on the Colchester site, one to work on the Ipswich site, to support the directors as we go forward, particularly with a focus around urgent emergency flow through A&E. But also we recognise that we need to put some specific work into 5 major areas. You can see there, so these 5 task forces that we've set up that are clinically led by our senior consultants and nurses, supported by our transformation team, to really simply maximise the benefit that we see with Epic. Epic isn't the solution to everything, but it's the biggest opportunity we have to all of our challenges, both in terms of access, some financial benefit clearly, but most importantly in terms of quality and safety. So we're looking specifically, as you can see there, inpatient flow, seeing how we can, we are able to treat some of our patients, particularly frail patients, in the community, but there's more we can do. If I could just tell you a story, because I was told it when I came into work on Tuesday. It's a 91-year-old woman who had a fall 4 days previously in a care home, was referred to the GP. The GP said take to A&E. So the ambulance service turned up, and because it was a Cat 3 and it was a lower category, although the patient was referred to the GP in the afternoon, because of the delays in the ambulance service, the ambulance didn't get to this woman until 4:30 in the morning. Woke her up, brought her into A&E, was seen by a doctor and discharged 5 minutes later. Now there has to be another solution for that poor woman who's didn't need to come to hospital. So really looking at how we can invest more in the community, again, looking at the 10-year plan and how we deliver the aspirations in there. Looking very closely at the third task force, looking at elective care, how do we maximise both the new theatres that we have on the Colchester site and indeed on the Ipswich site, obviously not relevant for our community here, but again, how do we reduce the waiting times for elective? And indeed, sitting alongside that, how do we improve cancer care? Many patients who are referred to us on the 2-week rule for cancer turn out not to have cancer. So really concentrating on those patients who we can remove from the waiting list really much earlier on, not least because it then provides reassurance to those patients and their families. And finally, what might look like a fairly small one is blood sample collection. This is something I've been pushing really hard in terms of if you look at how often a clinician might say to a patient, you can go home if your bloods are fine, and then they get referred to the phlebotomist who only does the urgent ones and then comes back 2 days later, and eventually they go to the lab and they're looked at later. This goes back and forth, and then the patient can go home. There's got to be a better way of doing that, so we're just looking at that. Finally then, as I've alluded to a couple of times, in terms of our mid-term plan, and I'm sure you'll hear more about this over the next few months and indeed years, are those 3 drivers in the 10-year plan. So the 5-year plan is our response to the 10-year plan, is a shift from acute to community. We're very committed to do that. The fact that we run our community services in North East Essex, and we are now a pilot for neighbourhood health. So we're working with DHSC and others as that being one of the first pilots, working with our GPs, working with our local authority colleagues in terms of how can we provide more safer, better care in our communities, not relying on acute care. Our shift from analog to digital, bit of a big bang approach, as I said, at 5:30 in the morning on the 2nd of October. But really, it's not just shifting the way that we deliver care, but it's using that as the catalyst to transform the care that we deliver. And finally, a shift from treatment to prevention. Although you may think, well, why is that the remit really of an acute hospital? If I just give you an example, we introduced something called Make Every Contact Count, which is asking our doctors often, but also some of our senior nurses, just to have a conversation with patients when they come in with their presenting ailment, which might be a hip replacement or a knee replacement, just to say, is there anything else troubling you? And by anything else, we mean, are there issues around your diet, your smoking, your drinking, your debt, your housing, all those determinants of ill health that we know about, but often people don't have access. So taking that opportunity of people when they're in hospital to ask that question. This year, we've referred 7,500 people, mainly to the third sector, around support, around issues that they didn't turn up with. So a real looking at prevention. A lot of that's around weight management, it's around smoking cessation, it's around people managing their alcohol intake. So really using that opportunity to support people around that prevention agenda was there with us as an outpatient. Chairman, I'll leave it there, if I may. Very happy to take any questions on what I've presented or indeed anything else. Thank you.
Paul.
Hi, thanks very much, Phil. I've got 4 sort of unrelated questions. So the first one's on your first slide, and sorry, I didn't want to interrupt, but when you were talking about statistics and the national targets, etc., and obviously the national targets being illusory to an extent, but how do you compare with the average? So, for example, the first target where you're at 56.
We're slightly below average for the first time in the history of SNAP. So our ambition is to not only get above average, but to get up back into upper quartile. The margins are really small. Yeah. So we sit in the third quartile, although we're just below average. If we improved for example, our A&E performance by 0.5%, that could take us into the second. And I think this is we're just coming up for the second quarter of the National Oversight Framework. It's relatively new. It will balance out, I'm sure. But I think I was talking to a fellow chief executive this morning on the way in, and he was expressing his frustration. He said that if you had two patients would have been seen on the waiting list sooner, they could have gone up a whole segment. So below average is, we don't even want to be average. We've never wanted to be average as an organisation, but that's where we sit at the moment.
Thank you. Second was how the orthopaedic centre is functioning and whether it's meeting expectations, etc. point. You touched on it.
It is. I think, to be honest, two things. I think we were probably a little bit over-ambitious in terms of the business case, in terms of how many patients we thought we could see. And secondly, I think it's taken slightly longer than we thought for people to get used to working in a different way. So I think we set a very clear trajectory about when we'd be at sort of 80 to 100%. I don't think any theatres in the country work at 100%. So, and also we did have a commitment from another organisation to send their work to us, and they then decided not to. But what that has done is free up capacity, which you'll be very pleased to hear about in Essex. We're now doing, I think it's 7 lists a week for patients from Mid and South Essex. So we've opened it up wider to the people of Essex because other people haven't taken up the slots that we created for them. So I think we're ambitious to get to 100% or as close as we can to 100% by the end of this financial year. I think we were too ambitious how quickly we'd get there, and probably a little bit ambitious in the business case. But there's some very honest conversations with our clinicians about what's the art of the possible in SEO. It's an amazing building. It's just incredible.
Yeah.
I know you've been, haven't you?
Yeah, I had to trip round as well.
Yeah.
Third one, just an observation on the My Chart, because Adam Brooks have been using it for a couple of years and absolutely endorse what you say. Theirs is a very odd feature, which I didn't know whether it's just observation, but I get an email from them saying, please complete your appointment checklist, before I get a letter from them saying, here's an appointment. So it's just bizarre that they actually bother having a paper letter coming out. So
Stop letters.
Yeah.
We've saved £15,000 in the first week of go live. So we don't. So if once you sign,
stopped all letters completely.
if you sign up with My Chart, then that automatically triggers stopping sending letters.
Yeah. Yeah, it's obviously some bizarre thing the way they do it. I just wondered if it was a feature of a My Chart, but obviously it's not.
No, there's a lot of internal flexibility around how we use Epic, and we've gone for the max, I think, which upset my finance director hugely, but I think it's good.
Yeah, it's so easy. Then the fourth thing was just about the national framework rankings generally. And obviously, I mean, I have a sort of conceptual problem with them because clearly half the people are going to be above average and half are necessarily going to be below. But I mean, it's notable that you're the best performing in Essex, and then the other Essex trusts are 20th and 123rd. Is there something about Essex that we should be worried about? I mean, ignoring the Royal Marsdens and the Moorfields, etc.
So I think if we look at healthcare across Essex, it's been, whether you go right back to the Essex success regime and everything. I think the allocation of funding seldom, for me, recognises some of our most vulnerable communities. And by vulnerable communities, I mean people who live in poverty. I think it's a word we're afraid to use, but I've never shied away from it. And I think the rating that we give, or the ranking that we give to people living in poverty, is not what it should be in terms of the national formula. So, look, it's not all about money. I've always said one of the several things that gets me into a lot of trouble with media. It's not all about the money. Last year in ESNEF we spent £4.5 million on paper and stationery. Next year we'll be spending a fraction of that. But I think there is something about the allocation to Essex. I think there are, we have to ask questions about why, despite the success regime and the way that health services are configured across Essex, I think there are questions to ask about whether or not we've got the right configuration, care in the right place. There is an over-reliance on acute care, and I think decades of lack of investment in community care and indeed technology.
More so in Essex than in other counties.
I think it's felt more acutely in Essex, and I think particularly the challenges that recruitment is difficult. Our proximity to London makes it difficult. Yeah. So London seems to drain people. If you live in the outskirts of London and you can earn London waiting, is it easier to jump on the train at Romford and go into Essex rather than go to Basildon or come to Colchester? Yeah. Probably yes. So, and also I think what happens in terms of income to some of the hospitals, that because again the proximity to London, a lot of the tertiary income, a lot of the money that could be spent locally on services tends to get brought into London. It's interesting. I spent 30 years working in London and argued London didn't have enough money. I spent the last 13 years arguing it's getting too much. So it depends where you're working, doesn't it? But I think that is a real risk to proximity to London, both in terms of staff and resource.
Okay. Thank you very much.
Thank you.
Jill.
Nick,
Hello, Jill. How are you?
I'm fine, thank you.
Good to see you.
And you too. Staying on the My Chart thing, you say you have to sign up to it. What percentage of take-up have you had?
We've had 50. I'm looking at Anna as the My Chart queen of ESNet. 53,000 patients so far, and that's in 8 weeks.
Wow.
So way above expect. I think we'd set 20,000 within the first 2 months. So we've absolutely and what's more important is that people are actually using it. I can't remember, Anna. You're checking a spreadsheet now, aren't you?
No, sadly, I know it.
So I think the interactions, it's thousands and thousands every day, isn't it? I can't remember.
It's huge numbers every day, and it's 28% of our active patient population are using it at the moment. We expect that to get larger every single day. So it can do an awful lot. It can welcome people into the into the clinics and things like that. So yeah.
Yeah, so you don't you don't even have to go to reception. You just click and say I'm here.
Yeah.
So I just clicked said I'm here. The consultant came and said I've just seen you've arrived, Nick. I don't think it's my surname that generates that response. It may be, but I don't think it is. I think I have checked with other patients.
And what was the hospital's choice to do this My Chart? Do you think it would be rolled out to the other, Broomfield, Southend?
Look, all organisations are expected to achieve an EPR, electronic patient record. I think it is unlikely that EPIC will be spread much wider across the NHS simply because it's the most expensive. We were very cautious with some of our COVID money. I'm not going to go into detail just in case the auditors are listening in. But no, we didn't do anything illegal, but we were very, very cautious with the massive additional income that we got for COVID, and therefore were able to kind of purchase what is the best, but also the most expensive. And it is significantly more expensive than others. It would be great, and we've tried for decades to have one platform that we all share. We do share with Adam Books, and we do share with, for example, Great Ormond Street, Guy's Thomas's Hospital, some hospitals in Birmingham, and down in the southwest. But there is no ambition to get one platform across the whole of the county. Unfortunately, it is ridiculously expensive, and given particularly the financial challenges of Mid and South Essex that we know about, I think it's unlikely in the near future they'll be in a position to purchase it. I don't want to speak for them, but that's just what I would suspect.
Thank you.
Anthony.
Thank you, Chairman. And just continuing on the My Chart theme, great to hear the success story. Great to see that a Big Bang approach was the right way to do it, and at least I hope so in the long term. I just wondered, or two things. One was, what's the integration of that with the NHS app, and does that mean that a patient has to transfer, or are the two complementary, or can you access My Chart through the NHS? So that was my first question. And the second was, what lessons were learnt in that transition, and how could those lessons be transferred to other trusts, particularly those in Essex that we're concerned with here?
Thank you for both questions. My Chart and the NHS Act will merge in the spring next year. So I'm checking with Anna because she's the, so at the moment they're on separate platforms, and you do need to open one and open the other, but they will merge in terms of so it will be seamless from the spring next year. Now, it could be a Department of Health spring, which kind of starts sort of 2nd of February and ends about the 3rd of December. So I can't be specific about the date, but that is the ambition. In terms of what can be learned, I mean, we are starting to do some learning from that. We've got a day where we reflect on what could have gone better and what could have. I mean, I think for me, the things that I would say is this has got nothing to do with IT. It has to be operationally led. Your operational teams need to be the ones driving it. Secondly, it has to be a narrative which is around quality and safety, and not just about numbers or IT or making it easier. And the third thing is to absolutely put the investment in, put the time in, because it's not something. Build some excitement, talk it, use the narrative. And it's great, for example, we were told that we needed 1,000 what we call ambassadors, so they're our own staff who are trained kind of experts in their own field that they would then, on the day we would go live and the following month, would be around to be at the shoulder for people like me who find IT a little bit challenging. Would just kind of help and everything else. So we're told we needed 1,000. We put out the invitation and we ended up with 2,000. So really engaging the whole organisation. We talked about little else for 2 years. And I think we did have the advantage that, the choice of Epic came from our clinicians. So every time they were a bit, I'm not sure why you chose it. I mean, not quite as direct as that, but they chose it, they wanted it. So they were excited about it, particularly people who used it at Adam Brooks or elsewhere. So just building that excitement, week after week after week after week, and having a really, really good training and infrastructure in there. So really investing in the training, which is ongoing. So we're still running the training programs, we're still keeping the energy high. And then finally, very, very quickly started talking about the benefits, particularly around patient care and things like MyChart. So it's all of that.
Can I just come back with a supplemental, if I may? In terms of the abandonment of paper and sending out letters, I know it's early days at the moment, but have you seen any effect on attendance at appointments? Has that improved the attendance?
That's a very good question. I don't think we're yet in a position to look at our DNA rates. We believe that it will, just because letters get lost and they get filed with something else and everything else. So I think the fact that you get a reminder, you get at least 3 reminders. Even it links to my Apple Watch. Even my watch is telling me that I should be with a rheumatologist next Thursday. So I think that will help. People rely so much on their smartphones now, don't they? And as I say, it's not for everybody. We need to make sure that we don't increase that kind of digital austerity and make sure that people, for example, we know that some of our communities have real anxiety about their smartphone because of the affordability of data. So we are having active conversations with the public around, if you're worried about this, then there are alternatives.
Thank you.
Dave.
Thank you very much, Chair. Thank you. And welcome, Nick. It's always great to see you here, and great to see you and your team are busy as usual. A few questions really I got, and one is to praise your staff. Because your staff is one of your biggest assets at Colchester. And I think I've been there recently, once with my wife and once with a relative that were there, and the staff were absolutely exemplary. The question really is about, I've got one about my chart, but I'll talk about that in a few seconds. It's a variation of a theme. Harwich and Clacton, I've got hospitals there. And I just wonder, with the capacity seeming to be so busy at Colchester now, I've heard you talk about this before in previous years about one day in the distance, it will not be big enough for the area. And I know you've got an outbase at Clacton, where 47,000, I think you've mentioned there, were being used there and seen there at the UTC. Is there a possibility that you could even consider, or your senior management team could consider, Harwich doing the same thing doing in the future to ease the burden of people travelling and your hospital at Colchester?
Yeah, thanks. I mean, I think that one day's come and gone. Every day we probably have between 50 and 60 patients who are in the wrong place. They're either in a corridor or they're being looked after as additional patients on a ward. Now, the key is they are being looked after, so we do not have any quality concerns in terms of patients looked after in the wrong place. But clearly, it is not a great patient experience. So I think that day has come and gone. You are all aware of the growth in Colchester itself, and the hospital was opened 30, 40 years ago, so it's simply not big enough. I've always argued throughout my career that it probably is big enough, we just need to deliver care differently. I think even with a shift from acute to community, more work with frailty, reducing admissions, the hospital is not going to be big enough. And we're already looking at how we can repurpose the hospital. It's unlikely we're going to get the 130 million we need to build new wards, so we're looking at how we repurpose. In terms of Clacton, I'm really proud of what we've achieved in Clacton. We're driving up the numbers in terms of the urgent treatment centre there. The new urgent treatment centre is now open, up and running. We've got another floor in there that was going to be a GP surgery, now not going to be a GP surgery. We're looking at how we can use that differently. in terms of providing an alternative to admission. Harwich, in fact, I've got some meetings next week with some GPs to see whether or not we can do a kind of hybrid GP stroke urgent treatment centre there, because the numbers that go through there are very low. But we also know that it's difficult to get to. You know, it's not easy out there on the coast. So we're constantly looking at ways of taking the pressure off the Colchester side. Happy to give you some more detail as those plans develop.
Thank you. The second question on that, Nick, is the diagnostic centres at Clacton, at Colchester, and they seem to be springing up everywhere. Pitsea, there's brilliant news. I think that I'm so proud of what you've done there, having experienced on 2 occasions the need for those diagnostic centres. I see there in your bullet point number 4.6, 12.5% of people are waiting more than 6 weeks. Is it a temporary glitch, or is it something to do about it? Because I always thought that the CDs, the diagnostic centres, were the future.
Yeah, we've had some specific issues. We put a new a new IT system into our imaging, our X-ray departments. That did not go as well as Epic, and we've still got some glitches there. So our diagnostics are not where they need to be at the moment. Clacton's a fantastic example in terms of MRI scanning, CT scanning, endoscopy, blood tests, cardiology departments, outpatients, and you know the fantastic. We had support from yourselves, the council, in terms of the millions and millions that we've invested in a part of our community that really need that health investment. We're building another CDC on the Ipswich site, or 2 actually, one in Ipswich town and one. There's no plans to build another CDC in Essex, but we are looking at maximising the opportunities on the Clacton site. Harwich, I think the jury's out a little bit, if you want to stay on that one. We haven't really got to a position where we understand what the strategic future is for Harwich. It's a constant conversation, but you haven't got that concentration of population on the Harwich site, so they'd still have to travel there. There's often if you put consultants out doing outpatient services and everything else, that can work. But if you're going to send a consultant out to, you've got to pay them to drive to Harwich, and they're losing time when they could be seeing patients. If you get a DNA rate or do not attend rate of 10%, you've lost all that time because they can't be doing something else. So whilst the principle is probably right, and probably more likely to use at Clacton than Harwich, there are some risks inherent within that.
And the last question is about, the one before my chart is the one about the corridor situation you mentioned. I'd rather have, personally, if somebody's in need and worried about, I'd rather have in the corridor than sitting home waiting, because you don't know what the risk is. At least they're being monitored in the hospital corridor. But the BBC in the press I saw a few months ago mentioned about getting trolleys past each other and the risk to that. I'm sure you and your staff are managing that risk. I've got no doubt at all. But what's the future for that?
Yeah, specifically on that corridor is now not used for patient care. To your wider point, we made a decision as a system that, and I would stand by this, is that the patient at greatest risk is the patient we haven't seen yet. So it is the worst, it is the better of 2 evils, because having somebody in the corridor as opposed to somebody having a stroke or a heart attack lying at home, the risk has to be less. It's not ideal, and we shouldn't become complacent. So we're opening, I think it's 30 additional beds by repurposing some of our admin areas. They open at the end of this month, at the end of, where are we now? We're not in December yet, are we? At the end of next month. And look at the Christmas lights, you think we're been and gone. But anyway, so yeah, we're opening, that will be opening just before Christmas. But also in terms of one of the task forces there, which is around looking at flow, which is about, if we took half a day of the length of stay for every patient, we would not have a patient in the corridor. That's the volume of people that we see. There are very, very few people that need to stay in hospital an extra 5 hours. And there is little or no therapeutic benefit from a hospital lunch. So let's just get people home before lunch. And it's a real drive. So it's not, it sounds really simple. It is simple, but it's not easy. So getting all of those, the most complicated thing we do in healthcare, and it shouldn't be, is to discharge a patient. There are so many variables, from the drugs they take home to the transport to the discharge summaries being written, a whole range of things. So that's our concentration. So what can we do internally to reduce the length of stay? What can we do to reduce admissions through the task force that takes it, particularly looking at frailty? And finally, what can we do collectively to make sure that we get the longer term investment onto the culture site, particularly with the plans around the growth in that part of our county?
Thank you. And my final question, I did promise this at the end, the My Chart. Now, I've signed into My Chart, but on NHS app, I see my medication repeats on there, but I don't see that on My Chart. Is that merger you're talking about?
It will. You should see a medication on My Chart. It requires them to be released. One of the slight anxieties I have at My Chart is, say, for example, results being released. So the first thing that anybody's going to do when they see their results is go to their GP. Not the GP you're thinking of, I'm talking about the Google practitioner, which is you're going to Google your results.
Sure.
So there is a risk there because people may get, misunderstand. So I think there's a balance between making results and medication, everything available. Obviously, you know what medication you're on. So there is an option there. It might be just the next time you're in, just talking to your clinicians just to see, free up that activity, that data or that detail onto your My Chart.
But thank you, Nick, and thank you very much for coming. Thank you.
Thanks, Dave. It was good to see you.
Thank you. Thank you. Lovely presentation, very promising. Let's hope you can follow it through. I just wanted to, have you got any information on the uptake of, is it My Chart or is it Epic, as to, the elderly people, which perhaps haven't got phones?
We haven't yet got the details, so we will do that. We will, let's say, we are very aware that it's not for everybody. So it's very important that for those people that can't use My Chart, first of all, to understand what the blocks are, what are the constraints, and can we help with that? But secondly, that if they can't or indeed choose not to, then we need to make sure that those alternatives for information, everything are still there. Now, if any of you have ever tried to ring a department in the hospital, you have, clearly. But of course, if now, as we know, 28% of our patients are now got My Chart, and that takes 28% of traffic to our medical secretaries or our outpatient booking appointments out. So what I'm hoping is that by doing that, the people who are still working in the hospital, answering the phones, giving information to patients, will have more capacity to do that in a timely way.
Thank you.
Jill. Yes, a question I forgot to ask with the My Chart thing. The people who are signed up to that and the link with, it's a triangle with the hospital and their GP, and you say you're going paperless. I know if I've had an appointment at the hospital, eventually, months afterwards, I will get a copy of the letter that's gone to the GP from the hospital. Will you still be doing letters out to GPs about a patient?
The information will go to the GPs electronically, so they will get the letter electronically the same time you get it onto My Chart.
Right. So the patients' GPs are linked into My Chart as well.
They have the access to the read only. We don't have access to their notes, but they can see aspects of My Chart, so they can see what's going on. And again, that will really help that continuity of care with an aim to get that care as seamless as we can.
So how will the patient know? Instead of getting a copy letter, will they get an electronic copy of what's gone to the?
Yes. Yeah, as I say, I got mine. By the time I'd left the clinic and got to my office, which was 5 minutes, it was on my phone.
Right.
Which is great, because I actually couldn't remember what she'd said to me. I think there's some information that you only retain about 20% of what happens in an outpatient clinic. So it's really good, because then I could say to, somebody said, what happened? Oh, let me just check what the GP, and this is what I did. I can never remember what medication I'm on. It's all on my phone now.
Right. Thank you.
Thank you.
Simon.
Just a quick question. You mentioned growth in the Colchester area.
Yeah.
We've got the garden village over the border.
Yes.
And they'll be using hospital in Colchester, not going anywhere else. We've got the thousands and thousands of new homes planned. Whatever repurposing you do and development you can manage, do you not think at some point that site is going to be overwhelmed?
Possibly. It's quite a large site. We have got quite a lot of space there. And if money were no option, I'd build a huge, enormous hospital opposite the university and then have a really link with the university and education and everything else. But it's not going to happen in my lifetime. But I think I've been having these conversations for years with local people. I think there's. Where I would be putting my investment, though, now is not into new buildings. It is about really investing in technology, really investing in making sure that, for example, we reduce the number of people who require inpatient care as much as we possibly can. The long term, the investment in prevention and supporting people with their life choices, but not just their choices, but supporting deprivation, supporting housing, supporting the determinants of ill health that we know about. 75% of the people in our hospital, and indeed any hospital in the country today, is there because of determinants of ill health. They're not there for genetic reasons. So I'm really pleased that the 10-year plan is addressing that, because it's recognising that the NHS will not survive in its current form with the demands unless we do something much further upstream. So I think long term, who knows? And I say that because I just don't know whether or not the government will give that investment, whether or not the public will accept a different way of receiving their healthcare. If they do, then I think the hospitals probably wouldn't need to rebuild. But I think the whole system of outpatients is out of date and archaic. The fact that hundreds of people, thousands, tens of thousands of people across the country will be going to an outpatient appointment today to be given information that they could have been given over the phone, to turn up just to see how they are, that could be done virtually, that could be done electronically. So I think and that frees up time and space, and indeed frees up clinicians, for example, surgeons, to do surgery rather than sit in outpatients. So I think with all that transformation, it may reduce the need for a complete new build on the cultural side.
Okay. Thank you. Anybody else? Okay. I had a couple of questions around the training, around the changeover from, what was it, 52 systems into one?
Yes.
That was very brave.
It was a moment, because we were supposed to go live at 4 o'clock in the morning. And it got to 5:30 and there were some glitches. And I had the clinicians on one side of the room saying, I'm not sure, Nick, I'm not sure. I had Epic on the other side of the room saying, we've got to go live now. And I thought, God, somebody's got to make a decision here. Well, that would be me. So it was one of those moments of my career. I thought, oh, here we go. I went, oh, go on then, go live. Yeah. So it was a moment.
I was very aware when they changed the MOT process over from manual to computer, and that was a night. I was going to ask a question around the around training.
Yes.
How long did you have to spend training your staff in preparation?
It was a really difficult decision, because if you train them too early, they forget, and if you leave it too late, there isn't enough time to train them all. I think we got it about right. So the really intensive training was really over the summer. So we waited, so about May, June time we started with the really intensive training. And then we ramped that up. So obviously some people need to, and all the different tracks, I can't remember how many training tracks there were, literally hundreds. So an inpatient nurse on this ward, outpatient, admin worker, managers, whatever else. So it took about 6 months in terms of the really detailed, but it is ongoing. And we know that you really get the benefit from Epic when you do the advanced personalisation, which means if you're a clinician doing pretty much the same thing every day, rather than going through and ordering this test, that test, everything else, you click one button and it orders it all. So that really, as you get more used to the system and you do that advanced personalisation, you get the real benefit to patients at that point.
Okay. Now, you mentioned earlier on that you picked on the Epic system, but it was more expensive. Yeah. What made you pick the Epic system, knowing it was going to be more expensive?
Because it was the best, and it's because so we had, I think we got down to a short list of 5. We then sent our clinicians out both to see the system live, see the 5 systems right across the country, see it, talk to the clinicians who were using it. We've had demonstrations of the 5 systems, and our clinical body said that's the one we want. And I went, great, I've got to go find the money to buy it now. So the decision was based on the clinicians telling us it was the best. Every study that's ever been conducted into EPRs internationally tells us that Epic's the best. That's why we went with that one.
Going forward, anybody else looking at systems, you would say
I
this is
would,
the one?
but yeah, there is, it's a big risk. I mean, eventually we'll get the money back, but it's £250 million. That's a lot of money to find.
Yeah.
So, but it's the right thing to do.
All right. Question that I know Jeff would often ask if he's here is, what do you need from us?
That's a really good question. Thank you. I mean, I think what I've enjoyed working with Essex and indeed with Suffolk, and this is my last HOSC. So I was just reflecting my first ever HOSC, which was in Croydon when they'd just been formed. Nobody quite knew what they were doing. We didn't know, and neither did the council. So I retire in 4 weeks. So this is my last ever after how many years of going to HOSCs. But I think what really works in Essex is public service right across Essex. It's pretty special, and I don't think we always recognise it. There is a real commitment, and I'm not singling out Essex from Suffolk in any sense. It's something we enjoy across the east of England, but there is a real commitment to public service. And you might think, well, of course there is, because we're all public servants. Believe you me, that is not the case. When I talk to my colleagues up and down the country, I think whether it's the Scrutiny Committee, whether it's Health and Wellbeing Board, whether it's whatever happens with ICBs going forward, the most important thing is, of course, you need us to hold us to account in terms of the residents that we all serve, the citizens that we all serve. But what I've found really welcoming in the few years, more than a few years that I've worked in Essex, is that it's always been from a position, and it's not point scoring, not knocking lumps out of each other for the sake of it. It is a real commitment to the citizens and the residents that we serve. And my ask would be just continue with that. Clearly, we've got the local government reorganisation coming forward. My plea would be, don't let that be a distraction, because it could so easily become a distraction for you and for many of your colleagues, whether as officers or as members. So whilst that is going on, and of course that's a worrying time for everybody for all sorts of reasons, let's not lose sight collectively of the people that rely on us every day to improve their lives. So that would be my ask, is to continue with that good relationship. Whoever succeeds me in the new year is to continue with that challenge, that critical friend, but also everybody recognising the reason that we're here every day.
Okay.
That'd be my ask.
Well, we'll be sorry to lose you going forward. Very
I
sorry.
need to lie down.
But I would like to suggest, with members' agreement here, that perhaps in 6-9 months' time we have an update on how things are going, particularly with EFIC. See what everything goes. So I think that's.
I didn't commit to anything this morning, but it won't be me, sadly.
How much longer are you there?
I go on New Year's Eve is my last day. So
What are you going to do?
Well, enjoy your retirement.
very, very good question. I'm going to do nothing for 3 months, he says, hopefully. But there was some interesting. There's some interesting. A few people have suggested politics, but I probably won't. I'll continue doing the media work that I do. As Nick Robinson said to me last
You've
week.
got so much knowledge.
Well, on the Today programme, Nick Robinson, I've worked with for many years, just can't wait for January, Nick Hume Unleashed. So we'll see. Thank you for all your support over many years as members and indeed as officers. So I shall miss you, and I wish you all well.
Well, I retired and became a councillor, so maybe we'll see you on this side of the table.
I live in the wrong county, but let's see. We'll let the local reorganisation sort itself out, and then we'll see what's left.
Well, many thanks, Nick, and
Thank you.
Enjoy your retirement.
Thank you.
Comes through.
Thank you very much.
We'll pause for a couple of minutes if we may. Switch the mics off while we reset the room. Just popped out for a second, but we're sure we're right to start.
Yeah.
Okay, we can go back live, please. Okay, we're here to welcome Tom Burton, Princess Alexandra Hospital Trust, who've come along with two other people. Perhaps they would like, we haven't got name tags for you.
No, that's fine. Can I introduce
If you'd
them?
just like to introduce yourselves.
Yes, so I'm Giovanna Lex. I'm the Chief People Officer for Princess Alexandra.
I'm Anna Jebb, I'm the Chief Operating Officer.
Okay, well, over to you, Tom.
Thank you very much. And thank you all for giving us the time to be here today. So we'll go through a few slides. We just don't want to labour on them. I'm sure you've seen them before, but we just wanted to talk about the journey we're on. I should praise you with two comments. One, firstly, apologies from another Tom. We get a lot of Toms over in Harlow, but Tom Lafferty sends his apologies today. Hence, we're here today. So apologies, he couldn't make it. Second thing, not probably for the first time in his career, Nick's probably stolen a lot of our thunder in what we're about to take you through, because we've got some very similar themes at PAH, as you would anticipate. But we just wanted to kind of take you a little bit about us. Conscious we have for a long time been kind of operating in a probably predominantly Hertfordshire-based system. Obviously, we've always been in Essex, and obviously with the local government reform, we're looking at orbiting back towards kind of the greater Essex footprint. So there's a huge time of change for us. And many of the areas that Nick talked about earlier, we've kind of been in, we're either slightly further ahead on, or we're implementing some of those policies ourselves. So can we just jump ahead a couple of slides? We've just got a bit of a filler slide of our most important people, our patients. We just wanted to, I don't know what you know about PAH, but we're a wonderful hospital. We've been around just over 60 years. Obviously, right in the middle of Harlow. We were built as part of the new town, and we have got unique opportunities and unique challenges from being in that very physical location. We're a lot smaller than Nick's Trust combined, and probably a bit smaller than Ipswich and Colchester individually. We've got about 400 inpatient beds. We've got a number of pressures on ambulances, like many of our colleagues do. We've got a very, very busy ED. Probably outgrown our ED a little bit because of that demand. We've got about just over 4,000 staff in our hospital. In just our trust, we're about £430 million turnover this year. And then we do around 5,000 operations electively and 48,000 day cases roughly. So we're relatively small but perfectly formed. We're also not just an acute trust. We've also got sites in Herts and Essex, in Bishop Stortford, which is, as you'll probably recognise, just in Hertfordshire, right on the border. And we've also got a big presence at the St Margaret's site in the south in Epping. And we are, part of what we're going to talk to you today about is obviously why we've been called here. So I'm going to let Anna introduce a little bit more on NOF. Appreciating Nick obviously took us through it, but we kind of just wanted to highlight a couple of areas. And then similarly, while we recognise we've got a huge operational challenge at the moment, we're echoing a lot of what we've been talked about in the 10-year plan. You know, if you read that, I think one of the opening gambits is about reform or die. We're very much trying to live that. We can't carry on doing what we have done as a historic just acute hospital. We are very much we're going to be forerunners in terms of really making that left shift and really doing things in a different way. So we'll talk a little on some of the operational aspects if we can. If we just jump to the next slide, and again, I don't want to labour on the points. We're used to usually presenting in great depth about our performance. I'm sure you probably don't want to get into the detail around that, but if we can just reiterate where we are, and I'll pass to you.
Sure. So just to say, I started at the Trust at the beginning of October, so I'm fairly new. We've got quite a new executive team, don't we? So
we do.
But the NOF, and I didn't hear the beginning of the last presentation, so you may already had an explanation of it, but it is the sort of national framework that NHSE have chosen to show how trusts are doing, basically. And Princess Alexandra is quite low down in the NOF at the moment, so 120th out of 134th. Could we move on to the next slide, actually? Thank you. There are lots of different domains in the NOF. There are about 22 indicators. I think a key point that's worth noting is it is entirely new, and the metrics that it measures are slightly behind. So some of them relate to Q1, and as you'll see in a minute, quite a lot has changed since the Q1 of the year. And when you actually come to looking at staff experience, that actually relates to our staff survey that was 1 year ago. So obviously over the last year we've done a lot of things with our staff and our patients in response to the sort of feedback we've had. So we are expecting things to improve when it gets updated quarterly, and this is just sort of a taster of what we have been doing differently, so you can see that. The other thing about the oversight framework is that NHSE use that alongside what is a board capability self-assessment. So they look at the outputs from your measures, and then they ask the boards, they say, how well led do you think you are? Do you think you've got good oversight? Do you think your data's good? That sort of thing. And so NHSE use that in combination with the actual metrics to make an assessment of how well your trust is doing. And that's very new. We've only just submitted our self-assessment. So the two are going to be used in conjunction. Could we move on? Oh, and I will just say the other thing is that if your trust is in financial deficit, you could be like number one in the country on everything in the NOF, and it takes you down to segment 3 automatically. It's like an override. So if you've got a deficit financially, which obviously lots of trusts do, you are marked down immediately, and it is impossible to score over segment 3. So that's worth noting. I'm just flicking on this as well in case it's a big screen. Cancer. So just to reiterate the cancer standards, because I think we often assume people know what they are, and just to explain them briefly. A key cancer standard nationally is that 75% of patients should receive their cancer treatment within 62 days start of treatment. So that's from the referral to start of treatment. And there's something called the faster diagnosis standard, and that means that says that 80% of patients should either be told from referral, should be told that they have cancer or they don't have cancer within 28 days. And those are probably they're considered the two most important standards around cancer. So these are the things I'm just going to draw out, and they're things that we didn't do very well in the NOF to start with. So in the first iteration of it. So if we could move to the next slide.
So yeah, it'll come back on. There we go.
Oh, sorry. I can see it here, but it's obviously not catching up. So just to explain where we are in the NOF at the moment on these two things. So the value that was used for our 62-day standard was 48%. We're actually currently now at 61%. So we have, for cancer overall, we are taking this exceptionally seriously. The reason it's obviously treated seriously nationally is it's a very urgent pathway for obvious reasons. Treatment quickly is linked to better outcomes for patients. That's why it's picked out and measured separately. We actually commissioned 2 external reviews to look at our cancer pathways because we were so concerned by the performance. And one was conducted by another trust and one was conducted by NHSE. So we have now combined that into an action plan, and we have been putting a significant amount of resource and attention into cancer pathways. And that's a whole multitude of things. So that's around additional capacity, additional diagnostics, making sure that we've got best practice pathways. We've been working a lot with the community because there are quite a lot of sort of triage parts of the pathway that we didn't have in place. So, and you can see this improvement now. So on the screen, you can see that our current performance, we've increased a significant amount, so 13% since the last assessment. So we're now at 61% for the 62-day standard, and we're at 77% for the 4-week standard, which is over the national average now. So we have made significant improvements, and we expect that when the NOF is updated, that will be reflected in where we land on it. I'll move on because I know it's sort of detail. Less. If we go on to the next one, please. Planned care. Planned care, you sometimes call it elective care, but obviously that's referrals in that aren't urgent, they're not emergency, and it's technically where you've got time to plan the appointment. That's why you call it planned care or elective. And the national target at the moment, it used to be 92%, but you can see where nationally we've come since COVID. The national target is now, at the moment, that 65% of patients referred in should receive treatment within 18 weeks. And there's also a target by March that only 1% of your waiting list should be waiting over 52 weeks. So if we go to the next slide, there are 2 areas that, another reason we were low down in the segmentation, so 120th out of 134th, is related to these 2 standards. So we had, at the point in time that it was measured, 51% of our patients got treatment within 18 weeks, which is not good enough. So that means basically half of them are waiting over 18 weeks for treatment. And at the moment, about 5% of our waiting list is waiting over 52 weeks, and actually that hasn't shifted much. So we're doing a tremendous amount of work, but shifting that sort of long waiting end of the waiting list is quite tricky. But we are seeing substantial improvements against 18 weeks. We're currently at just over 55%, and we expect to be at 60% by March 26. And again, the sort of things we're doing, they're not dissimilar to the cancer actions. It's all about demand and capacity. It's about best practice. We've got a really good example of improvement in dermatology. So dermatology was a pathway. We were getting a lot of referrals into the trust. And what's happening nationally now with dermatology in particular is everything gets referred in on a cancer pathway because primary care don't have confidence that things are going to get treated quickly if they don't mark it down as cancer, and then that means that you get overloaded, and it also means your diagnostics in the hospital get overloaded. So when you take samples of tissue, that's called histology, and it means that the histology services are overloaded and taking samples when they probably don't need to be taking samples. So we've done something really innovative in dermatology, and we've introduced as a pilot with our partners a community led dermatology service, which actually triages most of the referrals coming into the trust, and it's moved the performance in dermatology to basically compliance in terms of RTT and cancer. So that is something that, number one, we want to be rolling out permanently because it's a pilot at the moment, but it also raises the question about what we can do differently in all the other specialties. So there's opportunities in urology. We've got an MSK pathway. So this is a model that we think is a really good one, and patients are getting quicker, better treatment and not waiting so long. So that's where we're up to with planned care. Thank you. I think I'm handing over to Gio now for patient experience.
Yes. So we have a national survey around patients, the patient experience, and the survey usually comes out to patients around February time every year, but is about their stay with us in November. So that in itself is a little bit of a hurdle that we are raising nationally, because by the time that February comes, many patients perhaps don't remember, or they may just remember the negatives rather than both sides of their stay in hospitals. And this is not just with us, it's nationally. Now, we, unfortunately, last year's survey wasn't extremely flattering for Princess Alexandra. And there was a lot of concerns around noise in the evening. There is concerns around lighting, concerns about heat, and so on, or how we express how the staff talk to the patients, express the next steps when they go home, their care plan, etc., etc. Now, we took the feedback very seriously, as we do with all the surveys that we get, and we put a number of measures in place. In addition to support the patient experience, we've been doing a lot of listening sessions. We've been going especially into dementia carers groups to really improve the care that we give to our patients. And there is a whole plan, a whole program of work led by our chief nurse, Jo Ward, who is all about improving the experience. We also put in place now a program of work around neurodiversity as well. So we had a few walks with a group of not just staff from Princess Alexandra, but also external and patient panel to understand, as a neurodiverse patient, when you walk through the hospital, what do you see? So if you have potentially concerns around lighting or sound, and you go through the entrance and it's all that buzzing, and you started to get overwhelmed before you even get to your clinic. So we're doing a program of work to try to understand and move forward with all the actions that we can put in place and anything we cannot put in place because potentially it is not safe or we're trying to mitigate. So we're doing a lot of work because the patient experience, which is also staff experience, which I'll go in a minute, is really important to us because if we get our people, our staff, happy and content on the care that they deliver, and our patients feeling as at ease as they can in a hospital setting, the whole of the patient care will improve, length of stay will improve, and so on. So all the metrics will improve if we can improve our patient experience and our staff experience.
I was going to say just on that, Gia, I think one thing we'd probably just call out in all of that is we are very keen to hear. We always engage with our patients. We always engage with our staff in that sense. We have a very active patient panel. We very much, even though we're going to get onto our staff survey in a moment, just about it, we recognise that sometimes what we're hearing on the ground isn't being reflected in our survey, and we've got to make that correlation between the two, but we're really active in that space. I'm conscious we probably want to get to the nub of it, so should we just quickly go through staff experience and then we'll just kind of run through where we're going next.
Next one is up, please. Okay, so our staff experience is very similar to our inpatient experience. Last year, the engagement was less than 50% of our staff, but I'm pleased to say it closed tomorrow, and we already surpassed, and we are with a really good engagement this year. So waiting to hear the final results, but. It was not too dissimilar of our staff raising the concerns that they thought it was all about staff experience. We put a big program in place about recognition, about staff feeling safe to speak up, so it's our freedom to speak up culture. We're promoting a safe culture, and it will come across on our results, but I am pleased to say already that we done a shift in this last year on patient and people experience. I'll stop here, interest of time.
Hopefully improving, yeah, no, absolutely. We've got probably a bit too much. And we'll just rattle through this, because I'm sure you want to ask us some questions. So if we can just advance a couple of slides here. We're not just, just on that previous slide, sorry, it was, we have got some positives. And I think one thing we are all learning as a trust, and if Tom was here, he'd be probably saying we need to put our best foot forward. And it's easy to focus on the negatives, and that's probably the caution I would exercise around league tables. There are negatives, and we take them incredibly seriously. We aspire to be as good as we can be. We aspire to go up the league tables. We don't want to be here, if you call us back again, where we are now. We want to improve. But there are many things that we do well. And as I say, we are very financially challenged, but we're managing within that. We've got some really good levels around our HSMR data, which is our mortality, our sickness absence rates, but some of the national trends. You know, we are doing well in certain areas. We just always are striving to be better. That's why we just wanted to make that point now. And if I can just jump to the next slide, which is probably just a talk of the future. Nick talked really eloquently, and you asked him questions, obviously, about his community diagnostic centres, some of the community initiatives he's doing. We don't see the future of PAH just on the PAH site. You know, we are all about the left shift. We're working very, very actively with our partners. We're being lauded for it. In fact, we're going to present on some of the models we're trying to implement about trying to shift care out into the GPs, into primary care in that sense, because ultimately the most expensive place you can treat anyone is in a hospital. We have to run them 24 hours a day. They are incredibly resource-intensive places to be in. We're trying to make that shift where move as much as we can out onto the out into the community where it's better for patients, where it's more local. Invariably, that's the best outcome, and that's the best financial improvement metric we can use. Just a couple we're going to call out here. So, Health on the High Street. We're about to move into the Harvey Centre in February, where you'll be able to do phlebotomy testing. We've seen evidences of that being used in other areas around the patch, but we are very much working in partnership with Harlow Council around doing some of those initiatives. And our Community Diagnostic Centre in St Margaret's opens in early in the new year. We're doing a couple of final amends that we got some funding for, so it might push out slightly, but we're going to have an amazing Community Diagnostic Centre, and the St Margaret site is going to be a future of our neighbourhood health hub, which is very much the future talked about in the 10-year plan. So we don't just want to stop at imaging, we want to do as much as we possibly can at St Margaret's and in other parts of the patch in that sense. So I'll probably pause there because I think we've probably been through enough content. In terms of any other slides, I think we just had kind of a wrap up from there. So should we pause and take any questions, Chair, if that's...
Okay, thank you, Tom. Right, I'll come to you first, I think. As is your local.
From Harlow.
Oh, wonderful.
So, yeah, PAH has an up and down assessment most years. It's one year it's good, one year it's bad. Really, obviously you're waiting for your new hospital. Any news on that for a start?
Ongoing. So we are still, committed as per the announcement to have a hospital by 2035. But the programme itself hasn't probably advanced a huge amount over the last 6 months now.
Keeps getting delayed, and the residents, certainly the ones I speak to or speak to me, probably say it's never going to happen. But I keep persuading them it will happen. Yeah, I'm glad the I don't know how you pronounce that. Yeah, going into the Harvey Centre, which is great. That's in the middle of the town, because one of the main problems with the site is that the parking.
Yeah.
A, it's expensive, and B, there's not much there. I've never been able to park in there. I normally use the multi-storey across the road. So really, I've not got any direct questions. I think you've probably covered most of them. It was just I have had experience in there recently with the emergency care. I had to go, the doctor sent me for a CT scan, but I got through in 4 hours. So that was good. So I think the main problem, and I think we talked in pre-meeting, is we seem to be accepting that if you go to the emergency department, you're going to be queuing up for 5, 10 hours, 5, 6, 7 hours. That was a good experience. It's only 4 hours, and it's where they used to wait for their blood samples. That's where we sat, and the entrance was very in the A&E department was very welcoming in new chairs, and it looked very nice. So I'd like to meet with Tom, the other Tom. If that's okay. I'll try and ring. Who's the best person to ring? Do I ring his secretary?
We can give you some details. We'll feed them into your councillor.
Okay.
And we would love to have you and give you the tour. If I can just pick up those 2 points, Chair. Interlinked. I mean, did you want to come in on some of those points? But I was just going to make the point on car parking. Apart from the fact we're very landlocked and we have got very limited options, we don't have a multi-storey as some do. Half the problem is a lot of the patients that are in our hospital don't need to be there. So if we can make that left shift, it's got so many benefits because hopefully people will be seen quicker because only the patients who really need to be seen in that urgent care setting can be, and hopefully you'll be seen slightly closer to home or in a different setting if you're in Harlow. And secondly, if we can get less people, it would put less demand on car parking. I'm in my full job title, which I won't go into it so long, but includes infrastructure, which includes the car park, and it's probably one of the most resource intensive areas of my portfolio because it's such a contentious issue. We just don't have a solution yet, but we really are trying to work through some more longer term solutions. Did you want to add to that?
I'll just get on the 4 hours. If you come now to the emergency department, we've actually got a GP or 2 GPs streaming all the patients at the front door. So it would be very unusual for people to wait now at the front door for a long time. And you can go straight to our urgent treatment centre or our emergency medicine, same day emergency care service. So we do pretty well actually on the 4 hours. We do have waits if you end up needing to be admitted, which is not uncommon obviously nationally, and that's where we're focusing on. It's that flow through the hospital, but if it's something that we can turn around or if it's a blood test or diagnostic, you should receive care quite quickly. But I'm always interested to hear.
Obviously very welcome in the triage section, went very, very quickly. Had blood tests, I think, whatever I needed, checking this and checking it, then gone to the waiting, but that was very welcoming. So I went there reluctantly. My wife said go, and I said I don't really want to spend 6, 7 hours at the hospital. I can do more at home, So I did. But St Margaret, sorry, Chairman, is that a new build?
The new community diagnostic centre it's at the back end of the estate. So it's actually converting an old bungalow, but for all intents and purposes, it looks like a brand new building. We have the opening in, as I say, early spring. And if I can extend that invite, please come to the site. I extend that obviously to any member of the committee, and obviously we will communicate about a diagnostic centre opening. So you'd be very welcome.
Thank you, Chairman. Thank you, Nick. Tom.
Anthony?
Thank you, Chairman. And if I can go back to the inpatient satisfaction survey, I was interested to see that you've addressed the noise and the lighting issues by issuing earplugs and patches for the eye, rather than address the root cause of the problem. I just wondered why that was.
I don't think that's the only solution. I mean, again, I'll defer to colleagues, but the part of the environment we have is, it is an old hospital. There is only so much we can do. If you were doing a new building, they are completely configured in a different way in that sense. So the infrastructure itself is more of a challenge. Did you want to come in on some of the specific points?
Yeah, and I think Anna will do as well. So some of the concerns, for example, the noise was machines beeping. So it was the next patient who had a machine who beeped or who woke up. So is what Tom alluded to. So in a new hospital, you would have single rooms, so you wouldn't have that. What we have at the moment are big open areas with bays, with curtains. So anything that the patient next door do, it will, if you're light sleeper and you don't have anything to support you, it will wake you up. So there were some things that we had to mitigate rather than eradicate because it's not possible. But Anna, do you want to?
Well, I was going to say something similar. It is really difficult because you always, if you've been an inpatient, that there are always lights on somewhere on the wards. So that's why sort of masks, it seems pretty basic, but sometimes that is necessary. The other thing, obviously, is if you have patients that have more care needs or are likely to be noisier, if you've got choice as the nurse in charge, they would go into a side room, or you try and cohort patients with similar needs together. But obviously when flow becomes difficult, you end up you can't do that. You don't have the choice so much. But I think there have been massive improvements on that, and certainly like anecdotally feedback is experience on the wards is better, but it's one, I know it seems like the wrong thing to do, sort the original problem out, but sometimes it's things like that, and ultimately people don't want to be in hospital overnight, they want to be in their own beds, so I think we're doing everything we can, but yeah, the physical environment on the wards, you are very close together to the next patients. It is quite difficult to sleep sometimes.
That's why we'd love a new hospital, but on that point, Councillor McQuiggan, it's also the point that when that survey was done, probably an important point, Nick talked about the EPIC implementation. We had a similar implementation, not of EPIC, but we had that in November as well. So it was incredibly disruptive, just for noting at the time. It's not an excuse. I'm just saying we did have a lot of disruption in the hospital. So we hopefully, with a lot of the measures we're taking, we'll see that upswing, but we are constantly striving for that improvement.
I mean, I think it's sad that the hospital's in such a poor state at the moment and waiting to move, and that's been delayed again. But this is yet another example of unnecessary expenditure to solve problems that are there in the short term but won't be there in the future. And I was just surprised to see that and understand perfectly why you weren't able to attack it at root. Yeah.
Thank you.
Dave?
Thank you, Chair. Yes, thank you very much for the presentation and the executive summary. In the executive summary, you're talking about the NOF and that you had scored particularly low, and that since then you've seen your figures would definitely have given you a higher rating had that been the case at the time. And I think you mentioned quarterly updates. When's the next quarterly update, and what's your prediction? You've got a lot of clever people in your team, and I'm guessing you're thinking about what will we probably be.
In terms of the improvement, we can probably comment on that. I think that the challenge is it's a moving target, so we can know that they're not improving in terms of where our improvements are happening. The trouble is obviously everyone's moving at the same time, so I think it's very difficult to say we will be X. However, with all of the indicators we've got, we're moving in the right direction. So I would, if I can do the slightly ambiguous, it will be better. We just don't know quite where, unless you want to comment on any of that.
No, I think that's right. The thing is, it shifts. So as you improve, everybody else is improving, and it's always relative. So, but there's been definite improvement. I'd say cancer was the main thing. We've seen such a massive improvement. So I would really hope that we're higher. I would have thought it should update for the second quarter in the next month, but I'm not absolutely sure, so I think we'd have to come back to you on that. But fingers crossed it will look better.
Yeah, brilliant. And on to the background on the PAH. Obviously, we've had a scrutiny visit at the hospital before, and it is what it is. It's a 60-year-old building. but you're so busy. I mean, 400 beds there. You've got high ambulance demand, you mentioned in the slide, and high attendance at ED. The new hospital, I've just tried to Google and I've looked at the new PAH, you know, the app, the website, and all the rest of it. But it didn't tell me what the plan is for beds for the future and what that looks like. Is the future bright? I mean, it's going to take 5-10 years to build a new hospital, isn't it? But are those numbers going up from 400 that will make things easier for you?
So I think when we did the last demand and capacity modelling in earnest, and we're just refreshing all of that now, it was when COVID had just happened. I think given the shift in policy, our ambition would be that whatever our new hospital looks like, in theory, it should be smaller because we would have less patients needing to be treated in an inpatient environment. In terms of the numbers, when we looked at them, they're commensurate when we looked before, but we are doing all of that modelling in line with some of the shifts that we're doing. But in an ideal world, we would have, you know, it seems like a strange ambition, but we want as few patients in our hospital as possible because, you know, hopefully they won't need to get there. Prevention's better than cure.
But the area is growing, of course.
Well, yeah, it's an important point. So, I mean, Nick talked about some of the growth that they're seeing in the north of the county. Obviously, in Harlow, we've got huge developments. We've got the Gilston Garden Town as well. And again, it just goes back to the importance of partnership in all of this. That's why we're very much hand in glove with the council about how we plan for some of that. So we can't do this in isolation. We have to do it in a partnership.
Thank you for your answer. Thank you very much. I wish you well. Thank you.
Paul?
One thing, sorry, is that Anna?
Yes,
Sorry, I was saying this to you. You mentioned about that if you're in deficit, you're automatically in the bottom 50%. Is that something that has affected you? Are you in deficit?
Yeah, it's if you have a deficit plan in that sense. So yeah, it's even more nuanced than that. There's various tranches of money that are transacted within the NHS. There's kind of like the core money you do for your day-to-day business, and recognising that some people have got challenges. There's something called deficit support funding, which if you're given a share of it, though we have a balanced plan, some of the money that we are given is badged support funding. So if you receive that, that's what triggers you to suddenly be in that metric that Anna described. If you're in a deficit, it's much the same.
So you're automatically in that deficit regard. Sorry, that.
Yeah. So even though we're on plan, and there is huge risk with that, and I'm a finance guy by background, so we're pessimistic chaps at the best of times. But even in spite of that, we're kind of holding true. But because some of it's badged as deficit support funding, we trigger the lowest score.
Okay, thank you.
Any other questions? No. Sorry, Sharon.
Thank you, Chair. Just following on from Councillor Harris speaking about the NOF framework, obviously we know that league tables, for want of their word, have got their challenges, but the hospital trust ones have been quite public facing, and there's been quite a lot of discussion that we're hearing about from the public being aware that all of the hospital trusts that they've got for their acutes in Essex are very low in the rankings. And obviously they're not party to these discussions and these improvement plans. We're actually hearing through our information and guidance service real reticence from the public in almost wanting to engage with their hospitals because they fear that they are failing. That's how they're seeing it. So I know you can't speak for all of the trusts, but what are you doing to reassure the public and make them have confidence, if you can, in their hospital?
I think it's a really good challenge. So I think one thing, if we can say of Tom, and probably should have said at the start, we've got a very big exec team, and it's probably the newest member, I think, of the exec team. Tom's only been there a year, even though probably feels a lot longer because of the impact he's had. One of the biggest commitments that Tom had when he started was in externally facing the organisation. So we've had a number of consultation events. We had one in Bishop Stortford recently that, once again, is on the border of the Hertfordshire-Essex patch. But we're going out and trying to outreach and speak to our patients and speak to our communities and hear what they need in that sense. So I think engagement is, it's not one single thing. It's about making sure we actually physically go out to these interventions, but we really want to make our communications clearer. We want to make sure it's more accessible for patients and our staff as well to understand that. We've got, as part of Tom's initial plans when he came in, we've got a dedicated focus on a communications director who leads a lot of that external engagement for us. But for us, Tom is forever challenging us to go out within the hospital itself and be visible to staff and patients, which is hugely important. And secondly, we've got a number of structured events. So I think if there are future events, I think the last one technically was Hertfordshire including Health Watch, but we've got other ones coming up, and I'm sure you want to answer that.
Yeah, and also, I suppose Tom mentioned that as well. Our patient panel is led by an award winner, chair, and we have a really, really good, close relationship with them. So so even the event in Bishop Stortford, they were the ones setting up with us. To try to engage as much as with the public, and we do sort of monthly or every 6 weeks there is some sort of engagement, and we are trying, like Tom said, to engage with the community more widely. We are a lot more engaging with the council and all the charities around us as well. So it's to hearing not just the patient voice, but the public voice, the community voice. So and we are listening. So anything that comes through us, like Tom said, Tom Lafferty gives his email address to everyone and anyone, and every single email gets an answer within 24 hours. It may not get an answer, but it may get an acknowledgement and sent to one of us to sort it out. So we are, as the new executive team, we are really engaging and trying, because without that feedback, we cannot improve. And for us, it's all about improving.
I do think though, the proof is in the pudding in relation to access, and I think we do very good engagement, but we have to improve. And I think patients know if they're waiting a long amount of time, and what you want is to give people confidence that if they've got something urgent, they're going to get seen quickly. And so we absolutely have got a drive to completely change the position over the next year. So I am hopeful that in a year's time, people will see the improvement and have that confidence that you described, because I can see at the moment it must be anxiety provoking, but we do respond immediately. So and we also triangulate things so that we know that a large proportion of our complaints relate to patients on waiting lists who've waited. So we're looking at all of that, but I think it's sort of mission critical now to shorten the waiting list, make sure people are seen quicker. And then the other thing I'd say about it is the beauty of sort of models where the front end is in the community is that you do have an opportunity for people who for example, GPs who work in the community who know the patients to be part of that initial referral. So if you've got a risk that patients disengage or worry about it, then you get better uptake and more throughput. For example, with the dermatology model, I think those patients would say they've got complete confidence who have been through the dermatology service recently, and we need to make sure that we sort of use that where we can, because it's such a good pathway.
Thank you. Thank you, Chair.
Okay, anybody else? Okay, we heard Nick talking earlier on about his app system, Epic. Have you got anything in mind for something similar?
So the disruption I alluded to in November, that was our version of it. So we've got a product called Alex Health is our branding of it, but it's actually a version called Oracle Cerner. I've worked in a number of places across the NHS, and Epic is incredible, but it is probably unaffordable in a trust of our size in that sense. But that's not to say that Oracle Cerner, the product that we've bought, it does not have many of the similar benefits. It just probably doesn't go that last few percent that Nick's does. The portal that Nick was describing earlier, we have something similar. We're doing exactly similar measures about making sure that as we onboard patients, we do things like making sure we communicate with them digitally, and obviously that will integrate with the NHS app as well. So we have done that, and we're a year in.
So, and you're looking to go paperless in the same way?
Absolutely, yes. We had a discussion about it yesterday, funnily enough, but it's probably one of the biggest bugbears of, duplication, and we've got so many means of communication. I think it's very easy to kind of think, and the example that's used is elderly patients obviously don't want to engage in, or not all elderly patients want to engage in digital, but many do. So it's just, we need to break down some of those barriers, and if we make that transition to a new forms of having digital and people are using it, why are we still sending them letters? It's very silly.
Thank you. And the final question, which Jeff always poses, is what do you need from us?
I think, again, probably similar shades of as Nick described earlier, we are so committed to doing things in a different way. And I would hope what we're doing locally in Harlow is very symptomatic of exactly how we're going to change our approach in that sense. We can't carry on doing what we're doing. You know, the old model of just having everything in acute care, a lot of competition, trying to maintain our market share, for want of a better word. You know, we really want to put all of the money on the table, work collaboratively across West Essex, but that also extends to Greater Essex with the changes that will come from that ICB. So all I would advocate is please carry on thinking of not health and social care as this own thing that happens over here. You know, healthcare specifically is a team sport, and it's got so many determinants linked to social care, linked to some of those community initiatives. So please carry on engaging with us on health, and we will do great things.
That's right.
Comment, I think we did help in a way. We managed to get Robert Halfon to get the hospital, so well, that's unfortunately been delayed and delayed. Eventually you'll get your medical campus.
We're incredibly grateful, so yeah, thank you.
Yeah. Okay. Well, thank you very much indeed. Thanks for coming along this morning. We'll sort of pause for a few minutes while we reset the room. If that's possible.
Amazing.
Thank you.
Thank you so much.
Thank you very much.
Thank you very much indeed for coming along. Thank you. Much appreciated. To our agenda. If we're back online, yep. Okay, Health Watch, ADH, medication and shared care report. Over to Jo. Welcome.
Thanks very much. So I'm Jo, I work for Health Watch Essex, and kind of over the last, since about April, we've worked on this project around the impact at the end to shared care agreements for ADHD medication. Could I have the next slide actually? In the UK, medication for ADHD, if it's prescribed, it's usually initiated by a specialist provider. So that might be sort of at a hospital or other sort of specialist clinic. But when it's sort of stabilised, those specialists will often ask GPs to enter into a shared care agreement where they will then sort of share responsibility for that prescribing and monitoring. So the GP will do kind of month-to-month prescriptions, but the specialist should still sort of retain some responsibility for doing monitoring of that every so often to check everything's going okay. But these arrangements are voluntary for GPs to enter into, due to a sort of combination of factors that I won't go too much into, many GPs started to withdraw from these shared care agreements late last year, both for adults and children. Sort of early in this year, the ICBs did commission sort of new arrangements for shared care agreements. So instead of those shared care agreements being with someone's own GP, they'd be with the GP federations instead, but only for those who'd been diagnosed on the NHS. and that transition didn't necessarily go the most smoothly. So we ran this survey to look at sort of what impacts that was having on people with ADHD who'd been prescribed medication. And we sort of captured that moment where there was that period of uncertainty over the transfer. And we also looked at sort of the impact on people who had been diagnosed privately initially because of the sort of long waiting lists for the NHS services for ADHD, who felt they needed to go and seek a private diagnosis. They were then sort of left without access to NHS care, even though they'd previously had shared care between their private specialist and their NHS GP. And it also sort of touched on wider issues that this group had accessing medication for their ADHD. So the kind of main aims of this project were to look at how people with ADHD living in Essex were affected by GPs ending prescription and monitoring of ADHD medication. And we were sort of interested as well at looking at how the changes had affected different groups of people, so adults and children, whose sort of assessment are sometimes a little bit different, and sort of the transition between child and adult services isn't always that smooth. Also different parts of Essex, because as you all know, we've got the 3 different ICBs, and looking at sort of how the changes sort of played out in those different areas. And also people who were assessed through different pathways. So for ADHD, that can be through the local NHS pathway, private pathway if you're paying for that yourself, but also through this right to choose service, where it's paid for by the NHS, but with sort of an external provider. Can I have the next slide, please? Thanks. So we ran this survey across Essex, and there was also a parallel survey running in Suffolk to capture similar issues there. With Healthwatch Suffolk. We had 70 people respond from sort of a range of areas, so you can see the pink dots, people in the south, quite a large number of respondents from that area, the green dot, people from northeast Essex, and then far fewer respondents actually from West Essex. We did have towards female respondents. That's kind of normal for most of our surveys, but it's not representative, I think, of people on ADHD medication, because there's more males who've been sort of diagnosed and prescribed this medication. And this also, the people who responded to the survey, it's a mixture of sort of adults responding for themselves and parents and carers responding on behalf of children or people they care for.
Sorry, it's taking you the wrong way.
So we looked at how many people were affected in different ICB areas, and we found kind of that in Suffolk and North East Essex, everyone who responded to our survey who'd previously been on a shared care agreement told us that their GPs had already stopped prescribing or were soon going to stop prescribing their medication. So that's the kind of pink and blue bars there of people who were affected by this change. In Mid and South Essex, it was a bit more mixed. I think more GP surgeries there sort of continued to offer shared care agreements. There are a few GPs in SNE that have continued to offer shared care, but I think it's quite a low number, about 8 surgeries, something like that. And then in Herts and West Essex, we didn't really find huge problems with this specific issue. So no one told us that their GPs were withdrawing from shared care agreements. But as I said, we did have less people from West Essex. Slide, please. 30 seconds. So we also looked at different assessment pathways, so people who'd been assessed privately on the through local NHS pathways or right to choose. We also had a few people, the bars at the bottom there, people who'd had multiple assessments. So some people had been assessed by their locally through the NHS and privately, or right to choose and privately. It's quite complicated for some patients and some people who've been assessed abroad initially. So we had about 31% of people who'd been assessed privately initially, but who were assessed privately, 78% told us that their GPs had withdrawn from shared care, so they were being affected at sort of higher rates than people with NHS diagnoses. But it wasn't just people who'd been assessed privately who were being affected by this. The sort of pink and blue bars there, you can see quite a lot, more than half of the people who had local NHS diagnoses originally had been affected, and right to choose people who'd been assessed through Right to Choose had also been affected as well. We also looked at adults and children, and we found that adults and those who'd been diagnosed as adults as well were more likely to have been affected by the change. There probably has a bit of an interaction to do with the private versus NHS pathways, so we know that more adults sort of are able to seek a private diagnosis. We had in this survey 44% of people diagnosed as adults who were assessed privately, compared to just one person who was under 18. We looked at sort of the impacts that these changes had on people who were affected by them, and sort of the sort of quantitative and qualitative impact it had on people. One issue that we looked at was communication, how those changes had been communicated and how that had affected people. So the local medical committees had advised to GPs that they give sort of 3 months notice, I think was the sort of recommended amount of notice to give patients that they were withdrawing from these agreements. But we actually found that more than half of those whose GPs stopped prescribing gave them 1 month's notice or 1 month's notice or less, with 18% of people telling us that they received no notice at all, so they only found out when they went to pick up their next prescription. And in terms of sort of the qualitative impact that this had on people's lives, these revealed sort of issues with how the changes were communicated, lack of updates from people's GPs and the ICBs as well, and also in communication between services, so between sort of the GP and the specialist, or as well with Right to Choose providers and specialists as well. For example, one person told us, the way that I was informed was nonchalantly during an appointment for something unrelated. The GP was quite defensive when I expressed shock and concern and said that GPs weren't being paid to deal with ADHD. Next slide, please. Another person told us about their experience with their daughter being taken off. One person told us about the experience that their daughter had being when the shared care agreement was withdrawn. They told us, I was very concerned when I heard my daughter was being moved out from GP care for her ADHD. At the time, I had no idea how shared care worked. All I knew was that the GP would no longer be providing the medication that enables her to stay at university, and that I should wait for more information. Nothing happened and continued to happen after this as the deadline crept close. Next slide, please. In terms of arrangements going forward, so the FEBs did set up sort of new prescribing arrangements for people, but that transition wasn't always that smooth. So if you can see this big blue bar there, that's people for who no arrangements were made for their ongoing care at this period of time. And I'd like to point out that that includes people who'd initially had NHS assessments as well as private assessments. The amount of people in that sort of pink bar, people who had been referred on to the NHS, to another NHS service and were currently or soon receiving that prescription, is actually quite small. I think that's about 7 people. And we also found that some people were returning to private providers or on new waiting lists to discuss medication or on new waiting lists for new assessments. So that's mostly sort of Right to Choose providers. Next slide, please. So only 7 of those whose care had been withdrawn had successfully had their care transferred over to another NHS service, and 13 were not aware of any arrangements made for their ongoing care. Of those respondents who were waiting for a new assessment or a medication review, a lot of them, some of them told us about the impact that was having on their lives. One said, massive, feels uncertain, unconfirmed if I'll need to go through another assessment, which I don't want to, and there's no clinical rationale for this. And another told us, I haven't even been contacted. I've checked the referral on my GP records, but that's the only way to know that I've been referred. Next slide, please. Just to give sort of an overview of the negative impacts that these changes had on people, 88% of people told us that they'd experienced increased stress or anxiety due to uncertainty about their care. About 3/4 told us that they'd run out of medication entirely. And and more had also experienced delays in receiving their medication. Many told us that they needed to advocate for themselves more than usual, or that they were unsure about who was responsible for their care or prescriptions. Next slide, please. That sort of issue of the increased stress and anxiety and general sort of effects on their mental health because of the uncertainty and issues navigating care was a big issue that came up. So one person told us, the sudden withdrawal of support has left me feeling destabilised and uncertain about how to maintain continuity of care. Another told us, I'm now left in a difficult situation where I am unsure on where to go and who to talk to. And another told us, I'm very anxious about the next steps and hoping that there will be a U-turn in the decision. And there was a general sort of sense that people had tried to go to as many different sort of resources as they could. So they'd been to their GP. Some people said that they'd spoken to their MPs. They'd contacted pals. They'd called NHS 111. And at this period of time, no one was really able to tell them what the situation was, who to turn to, where to go. Next slide, please. It was also obviously affecting people's ADHD symptoms, and that was in turn kind of affecting sort of their ability to perform in work, in education, and also to manage their symptoms outside of that kind of medical aspect. One person told us, ADHD medication is not just a prescription, it's a vital part of how I manage my focus, executive function, and overall well-being. Without it, I've experienced depression, lack of motivation, and anxiety about my job. As a result of this, plus other factors, I'm feeling a lot more stressed about everything, and I'm not able to do the non-medical aspects of my symptom management because I don't have the time, energy, or money. Next slide, please. We also saw sort of an impact on people who were working in the NHS. We got quite a lot of responses actually from people who told us they were working in healthcare roles and said that they were worried about how not being able to access this medication was going to affect their ability to work in the NHS and their ability to care for patients. One person said, I'm an NHS nurse and I don't know how I'm going to cope. This is shockingly poor care and it will result in a lot of people becoming unwell and likely affecting their ability to work, likely myself included. And we also heard sort of stories from people saying that they were worried about their children and sort of what was going on with them and their ability to sort of take part in education. One saying that their child had become very impulsive and was sort of doing dangerous things in their sort of science labs. Next slide, please. As I said before, there were quite a lot of people in the survey who responded who had initially been diagnosed by a private provider. They told us that the cost of this diagnosis was up to £1,200 for assessment and titration, which is sort of that process of initially getting prescribed medication and sort of finding the correct dose for you. And those people had sort of felt like it was their only option to go to a private provider because of the long NHS waiting lists. Some of these people were now considering returning to the private provider because of being unable to access medication on the NHS, with sort of costs of up to £300 a month for private prescriptions. And some respondents told us they had multiple members in their family with ADHD, which sort of compounded those costs and made it completely unaffordable. Many people told us they couldn't afford this cost, and that they were then struggling while they waited for care through Right to Choose or their local NHS pathway. One person told us, I rely on my medication to help me work and be functional, but I cannot continue to take money away from my family's needs for private care. Next slide, please. We also had a sort of related issue to this, which was the disruption that people experienced when they moved into Essex from another place, be that somewhere else within England or the UK, or from abroad into Essex. Two people told us that they were travelling back to their home countries to access care. And one person who'd previously been diagnosed twice in the US and Germany, both places that have fairly sort of similar setups, similar sort of diagnostic criteria for ADHD, said that they were still waiting for NHS care after 2.5 years, having been put on a waiting list for ADHD for an ADHD assessment in the UK 2 years ago. They said they were still on the waiting list and had only just heard about this Right to Choose option recently. Next slide, please. How am I doing in terms of time? Because I've got a video, but I can skip the video if it's... Okay, cool. We also spoke to someone called Louisa, who had moved from London to Brentwood around the time that issues with shared care started popping up in Essex. And she'd just been diagnosed at the hospital that she'd been with in London. When she was then sort of passed on to her GP to do shared care, she was told that her GP wouldn't be able to do that initially. She'd previously spent 4 years on an NHS waiting list. She'd been assessed and titrated to a stable dose on the NHS, but then upon moving to Essex was told that she wouldn't be able to continue with that arrangement. She has actually now been prescribed her medication again by her GP while she waits to be seen by a right to choose provider, but she was left without medication for months. And she said that during this time she was struggling with things like impulsive behaviour and binge eating and difficulty sort of in relationships and at work. And we have a short video of her telling us how it felt to suddenly lose access to her medication that helped her to manage ADHD. Could you...
And you're like, I didn't know how to get it out. I didn't know. I was like, oh well, you just have to wait. And I was like, but what do I do? You have to go on the waiting list for 7 years.
Yeah. But yeah, basically she's saying that the impact on her sort of life and well-being was massive. And that sort of just that being unable to access that medication, having accessed it after years on the waiting list was sort of life-changing, and that then having it taken away, had a really negative impact on her life. Next slide, please. So just to kind of sum up, we found that being unable to access this medication and the kind of difficulty navigating care that then came along with that transitional period after shared care was withdrawn had an impact on people's ADHD symptoms, their life, their overall well-being. We sort of came up with some recommendations as part of this report that we produced. They're sort of in the full report if you'd like to have a look at them. But I'm also aware that the ICBs have already sort of been taking some really positive steps towards sort of investing more in ADHD services locally, and sort of setting up new right to choose pathways. So some of these issues are already kind of starting to be addressed, which is really great. So just kind of a summary of our recommendations is sort of that it's really important to sort of invest in these local NHS services. Some of the issues were also to do with sort of the causes of why GPs withdrew from shared care. It's really important to keep those relationships between GPs and specialist services and the local medical committees and service users sort of strong, and engage those groups in decision making, to provide sort of funding for those services and ensure that sort of this kind of thing doesn't happen again with other issues. And in the interim, people who are waiting to receive NHS care are supported. Thanks very much, and I'm happy to take questions.
Any questions? Yes, Paul.
I mean, we raised, because I was contacted by people I'm in West Essex, by people in February or so, and we got letters back from the various ICBs in May. Anyway, none of them sort of terribly satisfactory. But is there any sort of sign of some consistent approach across Essex?
I think in terms of across Essex, I think the different ICBs are dealing with it slightly differently. Yeah. I don't know if anyone else might be able to better respond to that, if there's anyone. I'm just looking. No. But I think I've heard from Mid and South that there's been sort of quite a large investment into ADHD services. I think they've released a letter announcing that in about September. And I'm aware as well of in SNE there's also been some investment into services. They're sort of setting up new right to choose services that would have both kind of assessments and medication prescriptions as well, and they'd sort of continue to manage that. And there's been I think some work with EPUT as well around sort of being able to continue some shared care agreements as well. But in terms of a joined up approach, I don't know if there's been kind of anything kind of consistent across the different areas. Yeah.
Sharon, yeah.
I mean, we've not seen anything particularly joined up, and I think one of our main concerns about this was that the ICB responses have been reactive after the event rather than preventative when things, were in planning, that they knew it was going to happen. Because what we found first was from people contacting us in panic saying, my medication's been stopped, I've gone to get another prescription, I've been told this is my last one. No explanation. And since then, the ricochet effect that it's had on people, we've had contacts around people that have retired or in ill health returning to work so that they can afford to pay privately for medication or to support other family members that can, people having disciplinaries in their work because they're now unmedicated and they're struggling to function and maintain the job that they've had for so long. And, scarily, people measuring and meting out their own medication, so saving pills for days when they're likely to experience more stress or when they've got an important meeting, rather than using them regularly as they should do to keep up those levels of medication, but saving it and hoarding it so that they can use it when they need it because they don't know when the next stock is going to come through or if they'll get more. So I think we've seen for a while now the effect on people, and it's great that the ICBs are sort of pulling things together, but to some degree, a lot of damage has already been done.
And what started this? Because it suddenly came up in the start of this year, didn't it? Was it just sort of cost saving on behalf of the ICB suddenly?
With shared care agreements, they're kind of voluntary for GPs to enter into, and I think a lot of GPs had been sort of entering into those without any sort of payment for them, and I think there was a bit of back and forth between the local medical committees who represent GPs and the ICBs about potentially starting sort of to offer payment for them, and there was kind of wider things going on with the BMA and sort of GP action that I think was kind of involved in the decision, and I think essentially basically I think West Essex was sort of less involved, but I think Mid and South and SNE both sort of presented some offers to the LMCs, and there was a bit of back and forth, and I think they kind of withdrew first from adults and then from children, something like that. And that was kind of December last year, somewhere around then, that they started advising GPs to withdraw. So I think that's kind of what sort of started it.
So what should we do as a committee, and what action would you like us to take? I guess it's sort of, so possibly preempting what you were going to say.
Carry on. What do you need from us?
Sharon, do you have any suggestions for that one?
I think to get that response, as when I raised the question at the committee last month, from each ICB, because it's not that whole coordinated system response across Essex, and I believe that a response has been received from Mid and South Essex.
Well, we got a response from each, sorry to interrupt, but in May we got a response from, or Richard got a response from each of the three ICBs separately, all saying slightly different things.
I think it would be good to get that update response to know where things are right now. We're still receiving contacts from people with deep concerns about their medication, and obviously addressing the fact that there are people that have been struggling for some time, months. For many of them, the medication was withdrawn back in March, April time, and things still aren't quite being sorted out for them. And obviously that's had a huge effect.
Well, it sounds like we need to follow that up.
Yeah.
Take it forward, if we can do that, Richard, please.
Yeah, amend it.
Okay. Anything else that you feel that we can help you with?
I don't think so right now. But yeah, thanks very much for listening to that.
There's no other questions?
I just wanted to say that I happen to have contact with a group of people in my own ward in Walden, and they're parents of children with, so adult children, not children, with ADHD and autism and other issues. And I know that this has been actually quite horrendous for them as well. So it's affecting a really wide group of people. And there have been people who have dropped out of university and, dare I say, actually have committed suicide. Not that this has been directly related, but that I know of an adult who suspects that's what caused us to undertake his own life.
Yeah, so it's a fairly important thing.
I thought I'd back it up with that.
Do we actually know how many people are affected?
Yeah, that's a good question.
So I think that's a hard thing for us to estimate, but I imagine it's possible for ICBs to estimate that.
Maybe we could add that to the letter to record how many people are affected and what's the next step. Yeah.
I think the other thing I would say as well is around sort of with this change, it's sort of real that a lot of the places that people would go in terms of accessing support, like I spoke to quite a few sort of community groups and sort of just kind of local support groups during this, and a lot of those are sort of providing like really good support, investing in those kind of like community support services for people with ADHD. A lot of them are kind of like general neurodiversity groups as well. But those support services are really, really good and really important resources for people. And I've done a lot of the work in terms of like directing people towards sort of where they can go and what the options are. So I think just kind of keeping in mind how important those resources are as well is a good thing.
Sharon.
Thank you, Chair. I think it's also important. A lot of the time, ADHD is always associated with younger people and people that can't perhaps function in society. And there may be some element of that, but what we've really seen is that so many professionals, as Jo said earlier, you know, healthcare workers, we've had teachers, and back in the summer, we released a podcast with a police officer who has been titrated, comfortable on ADHD medication for about 4 years. Prior to that, when the ADHD was unmedicated, was having disciplinaries, struggling, moving between teams at work. Because the ADHD was unmedicated, has been thriving ever since and was now put in this position where her medication had been stopped. She was genuinely fearful that she would lose her job. Her partner of age 75 was coming back out of retirement to earn money to pay for the medication privately. And that's just one case. There's a lot of people that are really contributing. Everyone contributes to society, but in key positions that actually are being put into this maelstrom of not being able to function. And that's going to have an impact wider as well. It will ricochet out.
Any other points? Okay, well, thank you very much for coming along. You've given us a few action points there to pick up and take forward. Hopefully we'll get some answers and we'll come back to you. But thank you very much for coming along.
Thanks very much for having me.
Okay.
Yeah, I was just looking at 6th and 7th of May when we got the responses and they were saying.
So some time ago now, so yeah. Okay. Next item on the agenda is the Chairman's report.
Nothing to report, Chair.
Yes, other than that he's sunning himself in Ireland. Bless him. Nothing else to report. Okay. Moves us on to item 8, which is members' update. Has any members got any updates they wish to mention?
No.
No, sir. Okay. I did mention a couple of things in the preamble, pre-meeting this morning. That we had a visit to Southend, the new Southend A&E some time ago. That's now up and running. From what I've heard, it seems to be running reasonably well. It might be useful to perhaps have a follow-up from that at some point,
like that,
to understand, you know, how's it working, what's happening, etc.
Thank you for that.
The other thing I was going to mention was around S106. You know, I'm not going to get away without saying that at some point. We are having, we'll come to it when we do the work programme, but I have been working with one of the local practices who are struggling very badly. We had a conversation with the local MP as well to try and understand it, and hopefully with the meeting coming forward, I'm hoping they can come along and talk to us and explain to us why they're having problems getting hold of this funding. So we're trying to organise that going forward. Anything else, anybody? Okay. Work programme, as you've seen, we've got Tom Abel coming in January, which hopefully he'll be able to talk about 106. But I believe Jeff was looking at doing some form of informal meeting in December, was he?
Yes, so the next formal meet will be in January. The meeting planned for the 18th of December will be an informal HOSC via Teams or Zoom.
So, okay. It gets away without providing the Christmas drinks, is that the reason? Okay, bring you have to have words with us. Okay. Work programme, as I say, you've seen. In there, anything anybody else wishes to add or comment on? Dave?
Yes, as I mentioned at the pre-meeting, Chair, there was a briefing in the last 10 days from the Director of Public Health, Muckle, Sarah, isn't it, Sarah Muckle, where it was mentioned about oral health, dental care, etc. It's mandatory to supply NHS, I asked a question there at the meeting, online meeting, about whether it was being met and where it wasn't, what the action plan was. And I guess it's a question that either she'll have to answer or she'll have to ask the ICB. So I haven't had an answer yet, but I wondered if the Health Committee wanted to similarly ask that question to make sure we get an answer in case we wish to put that on the work programme in months to come.
Don't see the reason why not then. Everybody happy with that?
Absolutely.
Okay. Anything else from anybody? No. Okay. Date of the next meeting we've just covered, 29th of January, and the full informal meeting on the 18th. There's no urgent business and no urgent exempt business. On that basis, we'll close the meeting at 12:43. Very much, as always.